Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we talked to Traci Beebe. Traci is a nurse who also happens to be Robin's sister. We talked to her about pain and inflammatory bowel disease and how challenging pain management can be for people living with IBD. We talked to her about the importance of case management and getting families involved in IBD care. And we talked to her about what it was like to be Robin's sister and a nurse during some of her most challenging IBD times. Cheers.
Hi, everybody. This is Robin. Welcome to Bowel Moment.
Hey, guys, this is Alicia. And what an exciting episode this is going to be because we are joined by Traci Beebe. Traci,
hi.
Explain why this is such an exciting episode. Who are you to us?
So most importantly, probably, and most notably, I am Robin's sister. Robin's older sister, in fact.
Yes.
Yay.
I was about to say my much older sister, but that's not. That's
Don't
not really
be a
true.
jerk, Robin.
That is totally fine. I am her much older sister. My mother had to think about it really hard before she decided to have any more.
She's like, I got it perfect the first time. Do I want to roll these dice?
It could be a bad thing.
That's right.
But on top of my most notable facts, I'm also a registered nurse, and I've been a nurse leader for more than 15 years. And several of my roles have been in abdominal transplant, gastroenterology, and leadership of all of gastroenterology at a large medical center in California, where we did all of IBD care. We did 10,000 procedures a year and grew that center to a center of excellence for advanced endoscopy. So a lot of experience in the GI world.
But we're going to bring it back to me.
I was going to say, we want to, we're so excited and interested about all of that, but we really just want to learn about Robin.
Perfect. That is exactly what I want to talk about.
But first, what are you drinking?
I am drinking a mocktail because I found a 0 proof alcohol that I really like. And so I have a Lily Koi martini. So it's Lily Koi or passion fruit and a little bit of lime juice and vodka that is 0 proof. So I get all the benefits of the fun drink and none of the benefits of the alcohol, darn it.
I absolutely love passion fruit. So that sounds really, really yummy. So I might have to try that someday because I love it. Robin, what are you drinking out of your plastic cup?
Guess what I'm drinking out of my plastic cup because it feels appropriate, but I'm in Louisiana right now. So I'm having some sweet tea.
Nice. I am also not drinking any alcohol today. I was so excited. I went to Costco, and keep in mind, I live in Minnesota, so far from the South, and they had a whole case of Topo Chico.
Yay! Topo Chico. We love Topo Chico on this show.
I got a Costco size pallet of Topo Chico. And then because it's the plain one, which is fine. It's fine. I still like it. I threw some raspberries in there too. So it gets a little bit of flavor in there as well. So, but I was really stoked. So yay.
Robin introduced me to Topo Chico. I had never had Topo Chico. I had only had some California brands. And I was like, this is the best sparkling water there is.
Anyway, not about Topo Chico, not sponsored by, but we'll take you if you want to. Yeah. Traci, give us your background.
I'll say this. Traci was still in nursing school in clinical rotation when I was hospitalized. So talk about that.
Yes.
Robin was very, very sick, got admitted to the hospital. And I was in nursing school, but I also worked at that hospital as a nursing assistant while I was in nursing school. So I knew the nurses, knew the people. And it was very scary for our family. We were very far away from our parents in Michigan, and she was not getting better. I can't remember how many days. It felt like 5 months. I think it was like 45 days, something like that. But she was in a lot of pain and they really weren't doing anything to control it. And she was continuously just getting sicker and sicker and sicker. And I remember the day that she told her surgeon, "Are you going to let me die?" And I don't remember if I was there or not. I remember the surgeon telling me the story before Robin did. And
I didn't know that. I did not know that the surgeon told you that before I did.
Yeah. So I remember Robin being brought into surgery, finally being brought into surgery. And it was a very long surgery. It felt like 10 hours. It was probably 6 hours, I think, 6 to 8 hours. And the surgeon came out and Robin's husband was there. And the surgeon just kept kept talking to me about her care and describing to me how her colon fell apart in his hands after he had removed it from her body and how scary this situation was. And he told me the story that your sister was right. She was going to die if we hadn't done this today, right now, without waiting. So Robin was, as Robin always is, just brave and stoic, and I'm going to survive it. I don't know how I'm going to survive it, but we're going to survive it. And she made it through that. She made it back home. She took charge of her care and her diet and her ostomy and her children. To this day, I think about that and I can vividly remember all of those moments, not just the overall, like this is what happened and it was a surgery and that was a patient and this. I can remember the fabric of the chair that I was sitting on in the waiting room when the surgeon walked in and looked me in the eye and told me that. I can remember Robin being in that hospital gown, walking down the hallway with one of her daughters. I can remember sitting next to her bed and the light coming through the blinds a specific way and it hit her face. And I still see that. That's how much it changed who I was and marked who I was. So I can't even imagine how it changed and marked who she was. I've seen all the things that she's done and I've heard about all the things that she's done and the people that she's interacted with just because, but I can't imagine how that changed her. And it hasn't stopped. It's a lifelong process that she's going through. But one instance in particular from a professional standpoint changed me. And that was her interaction and my interaction with her nurse on the unit, regular afternoon, not much going on. It was 20 years ago. So the hospitals weren't overflowing. The world wasn't ending. They had enough staff, but the mindset about pain was very, very different then. And what we were taught was very different. They were using the right words, pain is the fifth vital sign and pain should be something that is a perception and you have to listen to your patients. But in actuality, what was happening is that the nurses and the physicians were making determinations outside of what the patient was saying because it's a pain that you can't see. It's not a broken bone or a incision or anything like that. And so because of that, she had a PCA, I think at the time, and they were giving her breakthrough pain medication. And the nurse, Robin, was rating her pain 10 out of 10 every time for, I feel like, days. But this time in particular, I was talking to the nurse and I kind of got into a conversation and it totally became about me and this nurse. And at no time did anybody pay attention to Robin, the patient, and did anything to alleviate her pain until she was in so much pain that she had to advocate for herself. I couldn't advocate for her. Her nurse didn't advocate for her. Robin had to advocate for herself and was like, that's it. I'm done. You need to help me now. And throughout my nursing career and throughout patient care, I've seen that play out time and time and time again, where this population in particular, this patient population in particular, because it is not a visible injury, doesn't get the care and the pain control that they need to keep them A, out of the hospital because they don't need to be in the hospital, but B, so that they can have a normal life, as normal as it can be for them. So for Robin, she's done a really good job of finding ways to manage her pain and partnering with her team, partnering with her physician team, and really finding people that listen to her and hear her. But I have seen so many of these patients. They are the ones that are in the hallway on the gurney in the ER because they are not sick enough to go into a room and they just have to lay there in the hallway and get dilaudid here and there. They get labeled so that when they come in, they're known as frequent flyers, and they come in and it's only, give them their pain medicine and let them go. We do a egregiously bad job of managing this disease when it comes to pain and the support that the family needs as well as the patient, because pain and pain medication, narcotic pain medication in particular, affects everything. It affects your interactions with your children. It affects your interactions with your husband. You don't have energy. You don't have the ability to have a conversation. You're irritable. You break down your social structures. You don't have friends. You don't have family. You just kind of, it is really serious disservice that we are doing to this patient population when it comes to pain. And I witnessed it firsthand with my sister, and I've witnessed it again and again and again as a nurse. And we have to do better.
So first of all, I just want to say, acknowledge on the show that Traci and I have never talked about this. In 23 years, we have never sat down and had a conversation. Yeah, we have never had a conversation about the time that I was in the hospital, ever. So I might cry. And also,
for sure. I'm already tearing up over here because of her. So thanks a lot, Traci.
I apologize. I am not the new Barbara Walters. I am not going to make everybody cry.
No, we're joking.
But, so the reason why I advocated for myself. So another thing that my surgeon and surgical team did, who I adored that surgeon, by the way, like I really feel like he saved my life.
He did.
And I hold the highest esteem for him. He is now retired because it has been 23 years. But the night of my surgery, it was like 8 hours. I don't know, 6 or 8 hours. It was very long. And he added me to the end of his day because I asked him, are you going to let me die? And so the very next day that he was doing surgery, he added me to the end of his day. So I didn't even go into surgery until like 10 o'clock at night, maybe.
Yep.
But he sent my family home. So I came out of surgery and was expecting to see my husband at the time and Traci. And I think my brother was there too, or at least my brother was there when I went back. Right. And so I was expecting to see my family there when I got out of surgery, and no one was there. Like I kept telling the nurse, they brought me back to my room and I was kind of coming to, and I kept telling the nurse, where's my family? Where's my family? And I finally found out that they had sent them all home, and which was very traumatic. It was very traumatic for me to not be there. And then after surgery, I was in excruciating pain. So they had given me an epidural or something. I don't know. This was 23 years ago. But wherever it was, my legs were numb, but I could feel my entire abdomen.
So they did a spinal.
Okay. My legs were numb, but I could feel my entire abdomen. And they just removed my colon. And this is before they did it laparoscopically. So I had a 13-inch cut in my abdomen from, breast to pelvis, and I could feel all of it. And so I looked at the nurse and I grabbed her hand. I was holding on to the side of, I don't know how I remember this so vividly. I will never forget it. I grabbed the nurse's hand. I was holding on to the side of the bed and I just said, you have to help me. I can feel every single inch of my abdomen. Like I can feel everything. You have to help me. I don't know how I wasn't passed out from the pain, honestly. And she's like, well, they'll have to redo whatever they did in your back, the spinal or whatever. And I said, I don't care. Go to the anesthesiologist's house and get him out of bed. Like, I don't care what you have to do. I can feel everything. And so they got him back in and I had to roll over on my side and crunch up. And they replaced the whatever it was. I don't know. I'm not a doctor. I stayed at the Holiday Inn last night. And then finally I got relief. Like once they did that and he replaced it and the medicine started going where it was going, I finally got relief. But I could feel everything when I woke up from the surgery. And so that is why I speak about pain, because I don't know how I didn't pass out.
Just you describing that made me nauseous. Like it made me add, like I hurt and am nauseous just even you describing it. And so sweet mother of God.
I remember your surgeon saying that you would not wake up that night, that he was like, when he came out, I don't know, 3 or 4 in the morning, whenever he came in, he had came out, he talked to me for about 30 minutes about how the surgery went, what he saw, and said, go home and come back. He did. He told us all to go home and come back tomorrow morning, that you were not going to wake up, that because the surgery was so long, they were going to make sure that you were not in pain and that you would not wake up. And I was naive enough to believe that then at 30. So now at 52, and you don't leave anybody because you never know. And the pandemic destroyed that because we had to leave people and trust that they were receiving the care that they needed. And pain is not well managed. There are times when it is, like, again, orthopedic surgery, broken bones, spinal surgery, things like that. I've seen those patients be very well managed. Abdominal surgery, GI surgeries, OBGYN surgeries, just not a thing. Like, it's mostly women, so just tough it out.
From your professional perspective, why do you think that is? Do you think it is a little bit like, oh, women are stronger and they can handle it kind of thing? Or is it because, like you said, it's not a very visible pain? Talk more about why do you think this became a pervasive problem?
So in my opinion, it started off with pain in general being something that the medical provider could assess and treat as they believed the patient was experiencing pain. So for example, if you have a stoic patient who is not crying out or writhing in pain, and they say, I'm 10 out of 10, well, you're looking at them and you say, well, your vital signs are stable, your heart rate is not elevated, your blood pressure is not elevated, you are not screaming to me in pain. So my perception is that you are going to get the pain medicine that you need for what my clinical picture is of you. I don't want to vilify anyone. Most people are trying to do the right thing. They are absolutely 100%. We go to work every day and we want to do the right thing. But there is some unconscious bias about what we know from a clinical picture and what our assessment is. And so if you tell me you're in 10 out of 10 pain, but all of those other things look fine and you're able to speak to me in complete sentences and stand and walk to the bathroom, I tend to believe that maybe you're not in as much pain as you say you are. Maybe you're overstating your pain. Well, Robin is one of those people. And my experience is there are several groups of this patient population, IBD patient population, who are those people who have been living with it so long that they have to be to the point where they're ready to climb walls to go to the ER. And once they get there, they are so far behind their pain gap that they can't get to where they need to be. And they aren't treated with that same urgency. They're not bleeding out at that point. They're not, there isn't a broken bone protruding out of their leg. And a lot of this patient population, especially when Robin's time in the beginning, was female. So again, you're being dramatic. You're overstating. You can't possibly be in that much pain. Your heart rate is 80. Your blood pressure is 110/70, So I think that it started with the unconscious bias of the clinician, knowing and being confident in their ability to assess their patient. And then the narrative is there, like we're telling people that it's the fifth vital sign. We're telling people to listen to what the patient is telling you and go on what they're telling you. But when I do chart reviews, I still find that there are times where someone says they're at 7 out of 10, 8 out of 10, and they're receiving the pain medication for mild or moderate pain, which only goes up to 6. And what they're doing is they're saying they are starting them or they're trying to control their pain instead of just going to where they need to go. Now, the Joint Commission and our physicians have advocated for orders that are not sliding scale, right? So you have less of a window. So if it's mild pain, you give 1 milligram. If it's moderate pain, which is defined, right? So they've gone to the defining 6 through 8 out of 10 is moderate, that kind of thing. But they've gone to define it to start to take that personal bias out of it and ensure that we're treating patients. So if you come to me right now and say, I am at a 6 out of 10, you should get something for moderate pain, whatever your physician has prescribed. And it should be the full dose of whatever your physician has prescribed. So we have done things because as a medical team, we've realized that that is something that needs to change, but we haven't done the research yet. So we're doing the dosing better and we're listening a little better, but we haven't done the research to find out which pain medicine truly is going to work for this population, because giving them Dilaudid and snowing them is not the answer.
While we do love some Dilaudid.
Everybody loves a little Dilaudid, but Dilaudid doesn't do the job because you are not pain-free. You are just in a mild state of exhaustion, sleeping, and it has, done a little bit to help control your pain. But most of my patients, it's not like you get Dilaudid and you are all of a sudden at a pain of 0, 1, or 2, which you guys walk around in all the time. You are still at a 5. You went from a 7 to a 5.
Right.
That is not a solution. A 5 is still not your life, right? A 5 is still not being able to interact with your kids and interact with your husband and interact at work and be normal and be fully functioning and not exhausted and not short.
A 5 is exhausting.
Yeah. So that's what I'm saying. I'm saying that we have the ability to change the way we do this.
I am curious because so many of these pain medications have such significant GI side effects from them. Does that make this significantly more complicated? Is that part of what's creating a problem around treating treating people's pain appropriately in the GI community because they don't really know how to not fuck stuff up, for lack of a better word.
So yes, these medications definitely, but remember that with this patient group, right, we're talking about absorption, we're talking about receptors, we're talking about all those things. So there's so many components to this, right? So that's why I'm saying we have to do the research to do this better. One of my experiences was a leader over a pain clinic. None of my patients were IBD patients, not a single one. And in that pain clinic, they had psychologists, pain specialists, pain specially trained psychologists. I had pharmacists. I had a nutritionist, I had RNs, and I had physicians who were all board certified pain specialists. And we did all kinds of multimodal types of pain control to try to figure out the cocktail that's going to work while either eliminating or reducing narcotics for this patient population. There wasn't a single one of them that was an IBD patient. They just didn't get referred.
So I actually said not too long ago, I told my husband Matt that I'm going to have to go see a pain specialist because, well, first of all, most doctors cannot prescribe pain. When you
Correct.
go into a primary care or GI, OB-GYN, all of them, there are signs in their offices saying do not get pain medication prescribed here. And while I don't need it all the time, I do still find myself needing it. And I just told Matt, I was like, here's the thing, stigma. I don't know how many IBD patients are going to want to go to a pain clinic because we are already tagged as drug seekers. So if my GI, before I thought of it myself, if my GI had said, we probably need to get you to go to a pain clinic, I would have balked at that and drug my feet and not wanted to do that because IBD patients are already tagged as drug seekers. So, I mean, I realize now that nobody that I see can prescribe me pain medication. And I still find myself in a situation where I need it. And so I'm going to have to do that on my own. But now that you say that, I might reach out to my GI and be like, hey, will you give me a referral to a pain specialist?
Yes, somebody that they work with. But the thing is that we already have this model. So like for our HIV patients, I already have a model that has the pain specialist, the AIDS psychologist, the HIV infectious disease physician, the nurse practitioner, the pharmacist. We already have a model that works in integrated healthcare, like, Kaiser Permanente or the larger health systems, where we've realized that patients can't do all of these things, right? It takes time and life and appointments and this and that. So have everything. You come into your appointment and we have everything there for you. And like Mayo and those other ones can do that. Like spend 4 hours. You're going to spend 4 hours waiting to be seen anyway. Spend 4 hours with us and let's build relationship with our pharmacist who knows what the medications are and can do the homework, the NP or the PA that can work with you, the psychologist or the nutritionist that can work with you. And then you set up virtual appointments or do whatever you have to do, but bring them together in that clinic setting and get everything there. So you as a patient can trust that you're getting the care that you need instead of doing the farming it out, like sending you to the pain specialist and sending you to this and sending you to that, who aren't talking necessarily. That's the other piece. They're still not all communicating.
So this sounds amazing, but I should also point out that we are still trying to get our IBD doc to create a similar model or adopt a similar model just for IBD care in general, just having the PAs, NPs, mental health. I mean, not even all IBD docs refer out to dietitians that specialize in IBD, pelvic floor PT, like all of these things that help make your quality of life better as an IBD patient. We still don't even have that as the model of care. So baby step. Why not have a pain specialist included in that team setting?
And that's something that's billable and easy to do. So you have your IBD billable and easy, because we have to make it billable and easy, right? And Robin knows this. I've just spent the last 4 years in Hawaii, and the amount of private care or disjointed care, I mean, that is just the model of care out there. If you need to go see an IBD specialist, you have to get on a plane on the Big Island and fly to Oahu to see that specialist because you don't have a specialist. I have one doc on the entire island that does ERCPs, one on the entire island, and he's 102. And he's wonderful, but he's 102. So come on, we need to use our peers and make it easy for our clinicians to do the right thing. If we make it easy for them to do the right thing, they will. If they get reimbursed for it, they will. And then we've got to make it to where where the patients can trust us. Because if we put all these pieces together and we all talk each other up and say, this is the right thing and we're all here for the right reason, this will be the model. It's the only way we're going to really get there. And the research needs to be done around pain for this population specifically. I love that we are identifying genes. I love that we have got all these other therapies that you didn't have available to you 20 years ago. It's incredible the amount of wisdom and effort. But pain is ignored and pain controls people's lives.
I'm going to take that. I'm going to get you off the pain soapbox just for a second.
Please make me multifaceted instead of just a one trick pony.
No. I just wanted to ask you if you remember this because of how you said you remembered something so specifically. So when I was in the hospital and before I asked the surgeon if he was going to let me die, he actually did have somebody with an ostomy come in and talk to me because he thought, that might be a possibility of what was going to happen. But this is 23 years ago. So the internet was not what it is today, people. Okay. You went and printed off, I feel like reams of paper with everything that you could find about IBD, about ostomies. You brought them into me in the hospital, just like folders of papers for me to read, like I was actually going to read that stuff while I'm laying in the hospital bed, wondering if I was going to die. But I just loved that so much that you printed that stuff off. Do you remember doing that?
I remember getting help to do that.
Oh,
because I didn't have a printer at home.
People of the world, not everyone had printers
or computers
in their houses. I know this is shocking information to all of you.
But so I went to campus and started doing all of this and had to get the librarian to help me figure out how to print it. And she was like, what do you need this for? And I'm like, I just need it. And she probably said, okay, this chick is losing it. So we're going to help her.
Yeah.
And we're just going to get her out of my library because who knows what's going to happen next.
Oh my God, that's so funny.
But yeah, I had to go to the library. Can you imagine? Yeah. I remember there were ostomy pictures, like pictures of stomas and stuff like that, because most of it was just written stuff. But I remember there were a couple of pictures of stoma, black and white pictures of stomas. And I was interested because I had no knowledge about this. And so we were going to do whatever, like we're going to find out something, even if it's wrong, we're going to find out something. But an interesting thing for me is when you started to have this happen, there was a lot of things clicking into place. So Grandma Dot's issues with GI, Grandma Willie Mae's issues with GI, our issues with GI as kids, as young kids. Like my issues are different than your issues. We didn't have a non-eventful bowel habit life, right?
Yeah.
My experience was drinking mineral oil, tablespoons of mineral oil all the time.
Oh my God, I had to do that too.
I'm like, I want to blame everything wrong with my life, the fact that I had consumed gallons of mineral oil as a child. There has to be some problem. We should either be the healthiest people on the planet or there's got to be some genetic flaw because we consumed gallons of mineral oil as kids. God.
Where's the research on that? Is there a PubMed article on that?
I think it was snake oil. I think it was like the snake oil of our parents' generation. Mineral oil fixes everything, just like vinegar fixes everything for certain populations now.
Well,
you have a fever, vinegar.
That's the other thing. Just put some Vaseline. It'll be fine.
Well, my 3-year-old grandson had a fever and they pulled out the Vicks Vapor Rub. And I was like, wait, and they're putting it on the bottom of his feet. And I was just like, okay, talk about perpetuating a myth. What are we doing here? Now, Robin, you're not allowed to say anything because I didn't say anything.
I won't.
Thank you. Because I don't want to get in trouble.
No,
I am only Gigi. They can put Vicks on anything they want if they think it's going to work.
Can we go back a little bit? When Robin was first, of course, in dramatic fashion, diagnosed with IBD, you were in nursing school. And obviously she recovered. She did much better after that. And really, I mean, you were pretty symptom-free for the most part for a long, long time. I'm curious how that changed because you started in nursing school and then you continued in nursing school. How did that change your perspective as you were finishing nursing school and starting your career because of now having somebody so closely connected to you with a chronic illness?
So honestly, it didn't change anything because of how she recovered and because of how Robin and a lot of this patient population just handles it. So it was like, this is not a chronic illness. This was a really horrible thing that happened. They took out the offending organ because she was diagnosed with colitis, not with Crohn's, right? They took out the offending organ and she's never going to have a problem again. And we're going to do this takedown surgery in, a year. I think they wanted to wait a year because she was so sick. So she had to live with the ostomy for a year and nobody had to help her change it. Like after the first week or two, she just had everything under control and she perpetuated that. Like we never talked about how this impacted her marriage, how this impacted, she was seeing a dietitian at the time. There was somebody that came out to the house and helped her with what do I eat with an ostomy and those kinds of things. And she had told me about that, but because it was, you took out the offending organ, you're never going to have this problem again. And she went so many years without this problem that I think as a family and as a person, it was like, this is done. We can move on now and live these full, wonderful lives.
To be fair, nothing was as bad as it had been. So there was nothing to report, even though I wasn't perfect. So it wasn't as bad as it was when I was bad. So I must be fine. So no, I didn't tell my family anything ever. I've said this on the show before, but I didn't even tell my parents that I was being admitted to the hospital until after I had been in the hospital for a week. Traci knew because she was the one who took me to the hospital when I got admitted, but the rest of my family didn't know that I was being admitted to the hospital till after I'd been there for a week and they weren't letting me go home. Like it was like, okay, I guess I'm not going home. So I should probably tell somebody.
And I think that created for me this sense of chronic illness isn't chronic when it comes to this. Like there's a solution. And I'm always very solution focused. So for me, the first chronic illness that made me start thinking about this was when I was part of heart transplant and we had the congestive heart failure patients, right? And not the ones that ate crawfish and wanted to come in and get dialysis because they decided they wanted to eat enough salt to make them turn into the Pillsbury Doughboy. But the mom who was 22 years old, just gave birth to a healthy baby, but then wound up with cardiomegaly and was now going to be getting a heart transplant because she had given birth and she was this healthy, normal person at 22. And it wasn't until that, and I was old enough to think a little bit more, that I started to look at this population as that chronic illness continuation. And then Robin finally, when she was in Texas, finally started talking about what she was going through and what she was going to try to do and how she had not necessarily a platform, but a voice now. She had been given a voice to talk about. She had taken charge of her voice to talk about this. And that's different than anything up until that point that I can remember.
So as you're working with all these families, because of your experiences, and especially now that Robin has had a slightly more complicated journey with her now Crohn's disease, what advice do you give to family members? How do you interact with family members? Because you work with so many patients, sorry, Robin, I'm going to keep pointing at you, but like Robin, who are like, I can handle this. I've got this, stoic people. What advice do you give to them about like, hey, maybe they're not so great?
So that is the one thing that has 100% changed in my nursing career, is that I talk to the whole family and I make sure that the families get time with social work, case management, and the physician together. If it's acute and inpatient, everybody has to be in the room together. And we're going to have a case conference with the patient and the family, and whatever that looks like, however we have to do it. If we have to do it at 9:00 at night because they work or they're this, we need to make that happen, because I don't want to say knowledge, it's wisdom, right? The wisdom of how these professionals can help the whole family instead of it just being the patient, because nobody talks, like, let's say it's the husband, nobody talks to the wife and the daughter who's taking care of them at home, except for case management. Like, what do you need to go home? Do you need this or do you need that? Or well, they walk, they talk, they can still eat. You just have to adjust their diet. So no one really pays time and attention. Like, how do we prevent this, right? How do we change this from sick medicine to well medicine? medicine? How do we prevent this? And so we have those conversations as a team with those patients. And sometimes it's really therapeutic and amazing and things change and light bulbs go off. But, sometimes it's not that. And that's okay too, because they can't hear it at that time, right? So we just have to keep giving them the opportunity to have all those players in the room. And that's why I want to advocate for that pain improvement, but also for that team model of all of us doing it together, because then you feel and hear multiple times that story and you realize you're not alone. And the wife trying to help her husband, who's trying to do this on his own because he's 45 years old and he should be fine. He's supposed to be taking care of his whole family and he can't do any of the things that he was able to do before, like go play golf or play with the kids or help her around the house because of this, and this. Or the wife who's doing the same thing and the husband feels left out and they can't understand why they're always in pain and they can't understand why they don't want to get out of bed. Get up, let's go, let's do this. So that's what I think is going to be the most important thing, is to get everybody in the room. That's what's changed for me.
Yeah, that's really helpful. And I agree that I think sometimes a case conference like that may reveal information that was perhaps a little more hidden and give a better picture and a more accurate picture of what's really happening with the person who's struggling or, having to deal with pain and symptoms and things like that. So that's great advice.
Yeah.
It's super hard to believe that we're already like an hour into our conversation. So if you had one piece of advice for the IBD community, what would it be?
Advocate for yourself and then figure out with your GI a pain specialist that can help you, so that if they don't know somebody in that community, they can start thinking about it and start putting the pieces together so that you can do that. And then finally, give yourself a little grace in the process. It is not easy, and you get people on their worst day sometimes and you don't get the care that you need. Just a little bit of grace in the process and we'll all get through it and do better. We've done better in the last 2 decades than I expected. So I feel very hopeful that we'll continue to do better.
That's really good advice. And I'm going to add this to yours because you've already said it, but as another family member who had a loved one with a chronic illness, but that wasn't always very open with the things that were happening, that keep in mind that your loved ones are part of your team. And so there can be ways that they can be helpful to you, but they don't know what's happening with you unless you are willing to let them know what is exactly happening, what exactly is going on. If you're struggling, they can probably see it. They might want to know more, that kind of thing. So just keep in mind that you're not living in a bubble. You're not in a vacuum, that sometimes your perhaps family members can be more helpful to you, even if it's just supporting you than perhaps you're allowing at the moment. Robin just chuckles at me. She hates everything I just said.
No. I'm going to extend this episode a little bit. I will tell you that I have gone through periods over the past 23 years of making a conscious effort to actually be honest about what's happening with me whenever people ask, especially my family. And it is very hard to do that because I feel like if I shared how it really was, then I have to be honest with myself about how it really is too. And so if I continue to everything is fine and this is not so bad that I can't get through it, then I'm not going to, and I'm using this word air quote, complain about how I'm feeling, right? Because when you feel bad, a lot of the time people tend to not believe you.
Yes.
And so if I feel just good enough to get through, then I'm not going to talk about what it's really like.
Well, and I would imagine you'd be a little bit afraid too that if you start talking that people will treat you differently, you don't want to be treated differently. That's not why you're saying it, but that, that could potentially happen.
Yeah.
And I hear you. I hear you that admitting to some of this does make it feel more real, when you want to pretend that that's not the case, or you want to, continue to be like, I'm fine, I can get through this, I'm just going to put my head down. But, if there are things that people could do to help make your life easier, to allow you more capacity to cope, then let them do that, because people want to help.
Yes. I'm in therapy for this, people. I am in therapy for this.
So the other piece, I'm just going to add this one thing. The other piece is, if you give it a voice, if you begin to talk about it, then you risk somebody agreeing with you, and you risk the realization that it's not just today, that it was yesterday, the day before, the day before, the day before. Because I think when we are saying we're fine, we say we're fine because we can only have enough energy to look at today, this moment. Can I get through today to this moment? And if I talk about it and someone agrees with me, then we have to look back at yesterday, the day before, and it becomes a pattern of this. And then you have to deal with all of it, right?
That is true.
Whereas up until the point, you only had to deal with this moment, this 1 second, this 5 minutes. I think that that's true in this.
That is 100% true. That is how I realized that I was really in a player in 2018, because I actually talked to someone about how I was feeling. And that person said, you said this exact same thing to me 3 months ago, and you're not any better. And so it was that like, oh my gosh, I did say this exact same thing to her 3 months ago, like acknowledging that there was a recent past that I also wasn't feeling good. It is a conundrum. I'm going to keep being me on therapy.
I think that's hard though, because again, like you put your blinders on and you're like, I'm going to put my head on, I'm just going to live. And so, yeah, it's exactly right. Like, I just need to get through this moment and put my head down. And then, all of a sudden you look up and you're like, oh crap, this has been 6 months of me just getting by and not feeling well.
Or years. For a lot of people, it's years.
Yeah. And we are going to just continue to keep this episode going for another
forever. Traci, it is such a true pleasure to meet you and to hear your stories on this. And clearly we could keep talking to you forever. So thank you so much for joining us. But sadly, we're kicking you off the Zoom.
Yes.
So cheers, everybody. Thank you so much for joining us for Bowel Moments.
Cheers. Thank you for having me.
If you liked this episode, please rate, review, subscribe, and even better, share it with your friends. Cheers.